Hello everyone. It's an honour to be here. Thank you, Ronaldo, for organising this session and the organisers. I think it's been a fantastic session, and what I'm going to try and do on behalf of a fairly large group of people who are all involved with the work that we and others are doing that you've heard this morning is take the conversation on, talk a little bit about fluid bolus therapy, but also look at how we manage fluid generally and build the case, as the last comment that we had, maybe we need a clinical trial, maybe we need to turn our attention to more basic things, but build a case for a clinical trial and show you that it's possible, it would be possible to feasibly do a clinical trial using data from some of the large studies that we've done. And I think the first thing I wanted to say was that clearly as a community we have a huge interest in fluid research. I should have put a picture of the ANZICS party last night at the MCG, but there's a difference between the huge quantities of starch that are consumed by intensive care medical and nursing staff orally and the intravenous formulation that sick patients get. But that's just, Simon spoke yesterday briefly about the contribution that we as a community have made to global public health through the large clinical trials that we've done, and that's been enormous. But I guess what also is important is what the next stages are, and we've done a lot of work about type of fluid. There's more coming. Ronaldo and Paul Young are looking at plasmolyte and saline, and there's some very exciting work that will be published or coming to publication fairly soon. But also the issue of how we give fluid, how much, and bolus fluid is part of fluid management in general. Bolus fluid's one component. We can look at how we give maintenance fluid, additional replacement of electrolytes, all of that additional fluid, and how that impacts on fluid balance and fluid removal. And what we're really arguing for is maybe a clinical trial that evaluates how we do things usually, and then perhaps looking at a way in which we restrict what we do usually, so maybe giving less bolus fluid, less maintenance fluid, and comparing the two to see if there's a benefit for patients or not. Some of this data we've seen, I won't go over it. There's observational studies, there are some randomized studies that provide us with some information. The signal appears to be that a drier way of managing fluid in our patients may be beneficial, but it's not enough to change clinical practice, and really we need more high quality work to make sure that we get that balance between tissue ischemia and tissue edema perfect. So let's talk a little bit about fluid bolus therapy, and I'm going to show you just some data that's in the public forum already from the Safe Trips study that was done almost, I think, 8 to 10 years ago. Safe Trips was a cross-sectional study done across 400 international intensive care units, and it looked at how fluid boluses were given on one day. So it was a point prevalence study, and it documented the type of fluid that was given, but it also gave us some information about how fluid was given, and that's what we're going to just look at now. This graph, I think, is important because it makes the point that here on the y-axis, you've got the proportion of patients that receive a fluid bolus, and on the y-axis, you've got the number of days from intensive care admission, so 0 to 6+ days. And it makes the point that a third of patients on any given day, even beyond the first 48 hours, are receiving fluid boluses. And the median number of fluid boluses that are received, 2, with an interquartile range between 1 and 3. So 25% of patients are receiving more than 3 fluid boluses, even from day 2 onwards in intensive care units across the world. So that's a volume that could be somewhere between 750 mils up to 2 to 3 litres, depending on the volume that's given. And I wonder, when you look at data like this, you wonder, the resuscitation phase generally is early. So in ED, maybe the first 24 hours, 36 hours, but we're giving fluid beyond that. Undoubtedly, some of those patients need fluid, maybe because of losses, maybe because of poor perfusion, but we need to just ask the question whether some of that fluid or all of that fluid is necessary, and could it be that some of that fluid is having unnecessary consequences or some morbidity associated with it. The other thing that we can look at from the safe trips data is why people gave fluid. And I think the important thing here is that although nearly 40% of patients were receiving fluid because of impaired perfusion or low organ blood flow or low cardiac function, perceived low cardiac function, almost a third of patients were receiving fluid boluses for other indications, such as isolated abnormal vital signs, or just by unit protocol. And again, we need to ask ourselves whether that fluid bolus is strictly necessary in that circumstance. You will have seen this lovely critical care series that was published in the New England Journal over the last year. One of the early scenarios that were provided that we were all able to contribute to online was the situation of a gentleman with pneumonia, and some parameters were given about blood pressure, CVP, slightly on the low side. Overwhelmingly, the response to it was fluid, and more fluid. If you just go through the online scenario, it was all about aggressive fluid. And I think we've seen from the surviving sepsis guidelines, this is promulgated, but in the context of perhaps a literature that's evolving, suggesting maybe more careful, or perhaps a drier regime for fluid replacement. So let's just look at the chest data, and what I want to do over the next few minutes is just look at a subgroup of chest patients. So chest was a large randomized controlled trial of starch versus saline in intensive care patients who required fluid resuscitation. There were 7,000 patients in the trial, but what we're going to look at is the group that got normal saline, and we'll look at that group of patients that stayed in the intensive care unit for over 7 days. So that's about 900 patients, or just under. And what we're going to do is look at how we might try and reduce the amount of fluid that those patients got. So we can do this either by looking at how much bolus fluid they got, or additional fluid to bolus fluid. And I think in additional fluid, what we're referring to here is maintenance, electrolytes, drugs, and nutrition, so all bundled into one. And we're looking at how that might affect cumulative fluid input. Okay, so I'll show you some data that suggests how much of a saving we could make in terms of reducing fluid intake. And then on the other side, we'll look at fluid output and the effect of maybe introducing a diuretic after day 3, so after a nominal period of resuscitation that takes you up to the end of day 2. And we'll look at what effect that has on cumulative fluid balance. So this is just taking the chest population, looking at long stay patients, and looking at the effect or the amount of fluid that's given to patients or taken out of patients over that during that for 7 days. So this graph just shows you fluid input and output over the 7 days in those 900 patients. If you take the solid line at the top first, day 0 is a short day because it ends at midnight for the purposes of a clinical trial, and it's always, on average, it's about 12 hours in this data set. So on average, a patient got 3 litres on the first day, or day 0, 4 litres on day 1, and thereafter between 2.5 and 3 litres of fluid input per day over the 7 days. Fluid output is the dotted line, and I'm not sure whether the cursor does show up. So you can see that patients are relatively oliguric compared to, oliguric. They have a gap between fluid output and fluid input over the first 2 or 3 days. It's probably of the order of about 5 or 6 litres. But really from day 3 onwards, the urine output or fluid output matches or increases over fluid input, again at between 2.5 and 3 litres per day. That just gives you a feel for what's happening to fluid input and output over the first 7 days. And the median fluid balance at day 7 in this group of patients is positive 3 litres. And you can see from the interquartile range that about 25% have a positive fluid balance of greater than 8 litres at day 7. So this is quite a complex graph because it's got 4 things on it, but I'm just going to talk you through what's happening on this graph. This is a graph of the impact of reducing additional fluid. So this is not bolus therapy at the moment, we'll come to that in a moment, but it's all those other additional fluids that we give patients. And the top is what happens to a patient at the end of 7 days, a cumulative fluid input in these 900 patients. And we'll just work our way down as we do this. So the first thing to say is that after 7 days, these long stay patients have received a median of 22 litres. So that's the fluid input over 7 days. Now, if we add a nominal fluid bolus that would have probably occurred in the pre-ICU phase, say 20 to 30, halfway between, in the middle of the surviving sepsis guideline suggestion, if we add a 25 ml fluid bolus pre-ICU, so the median fluid input over the first 7 days is about 25 litres. It's a considerable amount of fluid. Now, if we were to reduce that, say by reducing maintenance fluid by half, maybe being a bit more conservative with the way that we give fluid with electrolyte replacement, for example, if we were to reduce that by a quarter, we would reduce the total fluid input over the first 7 days by about 8 litres down to 17 litres. If we were to reduce it by 50%, we would come down to 12 litres. So there is a potentially quite a significant saving if we were just to fiddle with the way that we managed maintenance and perhaps electrolytes. If we look at fluid boluses, and we're going to do the same thing, so the graphs are exactly the same as the previous one. We've got the baseline graph on top. Pre-ICU, we add the 25 ml bolus, so we've got 25 litres here. So if we were to reduce bolus fluid that was given to these patients by about 25%, we would reduce fluid, you can see 25 and 50%, we would reduce it down to 22 or 20 litres. So the bolus fluid saving is small in relation to the maintenance fluid and other fluid that we give, but it's still significant. You're knocking off about 5 litres if we could reduce bolus fluid behaviour. One way that we might do that is halve the amount of bolus fluid that we're giving, or perhaps have more stringent criteria for giving a fluid bolus. And lastly, if we just look at fluid balance now, so this is a chart of fluid balance, it's different to the previous two, and we're looking at fluid balance so that we can look at the impact of increasing urine output by using a diuretic. So again, we start at what the median fluid balance was at the end of 7 days, that's 3 litres, and if you add the 25 ml bolus, you get up to median fluid balance of 5. And now what we're going to do is increase urine output by using a diuretic to achieve between 700 mils and 2 litres of fluid removal per day. And what you do is the following. You shift that 5 litre positive to being -1, -3, -4. So another way that we could potentially, after the resuscitation fluid period is done, remove fluid to improve fluid balance. I think the major limitation of looking at the data like this is that we're not addressing the salt question. All we're doing is looking at fluid. And perhaps salt restriction, as Andrew Burstyn and Shailesh have argued quite well at our last few CTG meetings, is probably as important as the fluid question. So in summary, it is possible to substantially reduce the amount of fluid that we give patients. Can we do this in practice? We've done a survey. Neil's presented some results. There's another survey as well. Don't have time to go into that, just to get opinions. We've done some theoretical modelling. We're now developing a protocol and hoping to conduct a feasibility study in 4 or 5 ICUs to see whether we can implement a protocol that reduces fluid input over the first few days. How much fluid, just to tie this up, I don't know. I had this is what Simon Finfer would do. That's his current approach. I've put mine on the right-hand side. I think it's really hard, as Ronaldo so much more eloquently than I can, argued, it's really hard to know what to do. We all have our own individual practice, but somehow we need to put this together, I think, in a clinical trial so that we can test it and provide high quality evidence to change practice. And so the other option is to perhaps look at conducting a clinical trial rather than continuing to doing what we do now, and maybe find something that is acceptable to the intensive care community that could be generalized in a large clinical trial and answer the question. So with that, I'd like to tidy up and thank you very much for the time.
Thank you very much.